All right. Well, in the interest of time, we'll go ahead and get started. Thanks again, everyone, for taking time out of your busy schedule to join us here today. My name is Ryan Krodel with Nuvo, and we are very happy to have with us here Dr. Nadav Schwartz, who I will introduce in just a moment. Just a couple of minor housekeeping items before we get going. One of the questions we always get is, will this be recorded and shared? And yes, we are recording the webinar, and we will share the recording with everyone who has registered. So please feel free to share the recording with anyone you think would be interested once that goes out following the webinar. The other thing we always encourage is questions and discussion and dialogue. So please do submit any questions you have through the Zoom Q&A window. We welcome those and are interested in areas you have questions about or want to dive deeper on. So we'll take those questions as they come in throughout the presentation, if they're not going to be covered in another section of the presentation. And we've also made time at the end of the presentation for questions there as well. So please do submit those questions as you think of them throughout the presentation. So as I mentioned, we're very pleased to have Dr. Nadav Schwartz here with us for this presentation. Dr. Schwartz is an MFM at Penn Medicine and also serves as the Director of Imaging at the Department of OBGYN at the University of Pennsylvania School of Medicine. One of the foremost clinicians and researchers in antenatal tools and identifying pregnancy risk and guiding clinical management. He has a particular interest and expertise in remote fetal monitoring, among many other things. And fortunately, that's exactly what we're here to talk about today, and specifically looking at how we can expand the prenatal monitoring for those patients and those populations that need it most. So without further ado, I will hand off to Dr. Nadav Schwartz.
Thank you so much, Ryan, and thank you for all those that are signed on. And I'm eager to present, but I'm even more eager to hear about feedback and ideas from the audience, because there's lots of opportunities for innovation in pregnancy care in general. We all know that women's health and pregnancy care is sometimes not prioritized enough in the past, and even though the trend is looking better, we think that we're all on the same team here trying to really push the frontier forward. So what I'm going to talk about is remote pregnancy care and opportunities to innovate, focused mostly on remote monitoring. In terms of disclosures, I have received research funding, first from Nuvo, which is how I got started in this area, but then have since gotten funded from the ITMAT as well as the NIH. And I do serve on the medical advisory board as a consultant to Nuvo. So that's an important disclosure, but at the same time, the goal here is not going to be to endorse or sell any specific product or solution. We're going to be trying to address the general idea of how we can address barriers of fetal surveillance, raise the prospect of remote monitoring of the fetus, explore potential use cases, and like I said before, really get feedback from the audience. So we're going to try to keep it agnostic as much as possible to a specific solution or device, although if there are questions related to that, the folks that are from Nuvo I'm sure are happy to address those at the end or offline. So we're all familiar with this document, ACOG Practice Bulletin, which was updated relatively recently in terms of what are the indications for fetal surveillance. Now we know that the primary reason for fetal surveillance is to reduce the risk of stillbirth. And unfortunately, every pregnancy is at risk for stillbirth to some extent. That being said, to monitor every single fetus multiple times is expensive. It's not practical, at least with current technology and resources. So ACOG helps us with its indications and tries to give us some guidance, even if a lot of it is based on expert opinion and some evidence about which indications are going to increase over the baseline population the risk of stillbirth. But a lot of these indications, if you think about it, are increasing with time. So if you're looking at chronic hypertension, if you're looking at diabetes, AMA, the prevalence of a lot of the core indications that we think about in pregnancy are increasing in terms of the percentage of the pregnant women with these indications. So while it could be that with a very narrow definition of high risk, you might only get 5 or 10% of the population needing fetal testing of some sort, that number is significantly increasing to the point where in some institutions, 20 to 30% or more of pregnant women will need some level of fetal surveillance before delivery. And the list goes on and on in terms of the ACOG, back to the ACOG document, fetal growth restriction, decreased fetal movement, anomalies. We all know these tables. We're not going to go through them all now. But the point is there's dozens of indications for fetal testing at various gestational ages, weekly, twice weekly, individualized. And a lot of practices are struggling with how to accommodate all the patients. And more importantly, I think a lot of the patients are struggling with complying with these recommendations. But the problem with stillbirth is still there. And even though strides have been made over the last number of decades, the United States still has almost 24,000 stillbirths each year. That's around 65 a day, if you think about it. And over the last 15 years, there's not been significantly more improvement. In fact, between 2007 and 2017, there's been an increase of 18% stillbirth risk during that gestational age window of 32 to 37 weeks, which is really like the core late preterm area where you have a chance to salvage a fetus that has a reasonable outcome if you know when to intervene. And some, including the March of Dimes, have estimated that 25 to 75% of stillbirths are preventable. And a lot of that is preventable in terms of healthcare access, education, and improving the health of the mom entering pregnancy as well as throughout pregnancy. And in addition to the fact that these numbers, unfortunately, are increasing and not improving enough, there's also significant disparities, as we see that Black patients are 2 times at greater risk at every gestational age for having a stillbirth. And that disparity, again, has gotten much more attention over the last number of years, but solutions in terms of actually allowing us to directly address this kind of disparity, increasing access and addressing social determinants has not necessarily succeeded yet in narrowing this gap. And what ends up happening is that you have the underlying comorbidities that we mentioned are increasing with time and over the population. So you have sicker patients getting pregnant with more risk factors coming into the pregnancy. And often patients without access to care are having undiagnosed conditions, didn't know that they had high blood pressure, don't understand enough about or haven't been given access to good nutrition or nutrition education, et cetera. And they have the more comorbidities. At the same time, those same social determinants are hindering the in-person care. They don't have as much access, the cost of transportation and childcare, their inability to be flexible with their job, lack of social support network and education, et cetera. And together, those are working, unfortunately, to continue to drive these disparities in outcomes, both on the fetal side and the maternal side. So I wanted to go through some very, very just basic kind of cases. And again, the goal here is just to open up the mind, because I've been in MFM now for, I guess, over 20 years. And I think that, you know, we are taught a certain way based on certain technologies. And in order to really be disruptive, we have to be willing to just keep it simple, but also think a little bit outside the box and just have a little mind exercise about what things can look like. And then we have a sort of our North Star to what to shoot for. And so just take a case, which I think that any of the clinicians on this webinar, I'm sure has faced something similar, if not identical. So Joan is a 33-year-old G4P3002. So she's lost a pregnancy in the past. And now she's being recommended to have twice weekly testing starting at 32 weeks. And she also has comorbidities. And again, this is mix and match. You can chronic hypertension, obesity, diabetes. We have a patient with significant risk factors that does need increased surveillance because she's at risk for an adverse outcome. Now, she understands this risk. She's well counseled. She came to care. You do your best to explain to her the risks and the need for increased surveillance. But what we often don't do in the clinic is consider the fact that she has 2 children at home. Her husband works long hours in order to just get food on the table and make ends meet. They can't afford extra childcare. And she has to take 2 buses to get through city traffic to just get to come to any visit. And now you're going to ask her to come in twice a week in the last 2 months of pregnancy, when she's probably the most physically uncomfortable, let alone multitasking to the nth degree. And it's a significant burden. And so, you know, if we're really going to be taking care of the whole patient, what can we do to address some of those things? And as opposed to just saying, here's a recommendation, now it's on your shoulders. And unfortunately, what often happens is that these patients can't do their best, and they can't necessarily comply, and they put themselves at increased risk, or at least more risk than they otherwise deserve. And when I was starting to get into this work, we did some preparatory sort of discovery work in our clinic, both to understand the magnitude of the problem, and as well as in preparation for various research projects and grant applications. But we found that we have a very high no-show rate in our practice, where you can see on the graph there on the right that that 75% of NST appointments were actually kept, and that's a significant no-show rate. But more importantly, you see the disparities, that Black versus non-Black compliance with the appointments was stark, and that was definitely eye-opening for us. So we did a little survey. We took 60 patients and gave them a survey, and said, and a quarter of them around had missed at least one appointment, and we just asked them lots of different questions about their testing experience and barriers, et cetera. And by far, the three primary barriers that were raised by our patients were transportation costs, childcare issues, and work conflict. All of three of which, if you think about it, are something that we as a healthcare industry have imposed on our patients by requiring them to come to us, as opposed to finding ways to meet them where they live. And the vast majority, just on the face of it, this is before we offered them a specific product, like the concept of remote solution, that they would be open to the idea of doing more of this work at home. And this was done before COVID. So imagine all of the other trend and acceptance of telehealth virtual care that has definitely been accelerated by the pandemic and the access to care issues that it raised. So what we're trying to do is break this cycle of inequity. We have the greatest barriers of care to the patients that need the most help. The patients that need the most help often are the highest risk, because they often have comorbidities and other issues that are impacting their risk factors. And then we tell those same patients, you need to have more visits than everybody else. And because you need more visits than everybody else, and you can't necessarily access them because of your barriers to care, you become higher risk, and it becomes a cycle. And we need to find a way to break that. And we know that telehealth in general has had some success in addressing some of these issues. And ACOG has recognized it in its task force, saying that telehealth is increasing, it being increasingly used in all aspects of OBGYN. And then the MyPath, which was the Michigan plan for tailored healthcare that ACOG and University of Michigan collaborated on to try to help give a framework for how to individualize care, how to be more flexible with our approach to care, how to directly address issues of social and structural determinants. And a lot of the solutions offered were sort of surrounding telehealth and hybrid options. We also know that there are a lot of programs that have shown success. At Penn, we're very proud of the Heart Safe Motherhood program that my colleagues have developed for postpartum hypertension, that is being expanded upon and showing reductions in postpartum admissions to the hospital and reductions in disparities of care. And that's a text-based platform. There's other telehealth prenatal care visits, and the literature is just full of papers of how these efforts have been successful in increasing compliance with care and reducing disparities. And so it's hard to say that there's a silver lining to COVID, because the pandemic was very just disruptive and destructive. But it did sort of make the field open up their eyes and think outside the box and be open to these remote solutions. And there's other examples of this that I'm sure you're all familiar with. But one thing that the current problems don't address is fetal surveillance. So even a lot of the papers that came out during the pandemic, this is how SMFM or specific institutions dealt with the crisis of how to reduce the number of in-person visits. None of them had a great solution for what to do with fetal testing, with fetal surveillance, with patients at risk for stillbirth. And that's because the technology wasn't there yet. And so that's what we're going to sort of try to think through. So when you think about antenatal fetal surveillance, and the ACOG, it's all in the ACOG practice bulletin as well. We know about the non-stress test, the biophysical profile, the modified biophysical profile, and then less commonly used nowadays, especially in an outpatient setting, but the contraction stress test. And the bottom line is that even though there are differences, they all have a very, very high negative predictive value, meaning that the risk of a stillbirth in the week after a normal reassuring test of any of these tests is a fraction is super low. We're talking about less than 2%, 1 to 2%. Now, there's other things that we can do to try to reduce that further that we can get to, but all of them are acceptable per ACOG as the primary screening tool. But they are not the same, right? The non-stress test requires a CTG device in your office. The biophysical profile requires the CTG for the non-stress test plus an ultrasound for the other parameters of the biophysical. The modified biophysical, again, needs both the CTG and an ultrasound. And the contraction stress test needs a CTG device and then medication, usually medication used with Pitocin or oxytocin to stimulate contractions. So there's different amounts of resources needed for the different kinds of tests out there. And adding ultrasound to the non-stress test can get you an incremental increase in the negative predictive value, but it does require a significant increase in resources and might be more difficult to translate into telemedicine. So currently, since the CTG devices are in your office and we don't have anything to send that patient home with, maybe we do, the telehealth in these fields are not developed. There's not a lot of telehealth happening in fetal monitoring. But if we do have devices on the market that can allow you to get a fetal heart rate trace and uterine activity, i.e. the non-stress test, we will then be able to have a primary screening tool for fetal testing that can be amenable to telehealth with just one device. So in that future picture, when we have such a device that's or such a program, now we can rethink how Joan's experience might be. So yes, Joan was recommended to have twice weekly non-stress tests. However, the clinic now decided to move the needle, think outside the box, and let's have a remote monitoring program because we want to meet the patients where they are. And sure enough, she signs up for it and she's able to put herself on the monitor while her children are napping. She has a neighbor on standby that can occasionally, if some in-office evaluation was required, can sort of step in, but that's much better than having to go in twice a week. And thankfully, she's able to adhere to her recommended surveillance and have a nice, healthy baby. Now, barriers, as we mentioned earlier, can take many different forms. We talked about employment, we talked about childcare and transportation, but there's also a mental health thing to consider because the mental health crisis is also something that's very a growing problem throughout all age populations, but especially in the younger age population and people of childbearing age. And how do we reduce that anxiety? We know that patients have shown a preference in many situations for virtual prenatal care. They're scored higher in many studies when they have a virtual or hybrid option. A majority of patients will prefer that, in fact. We know that anxiety is a significant problem in the Gen X and Gen Z patient populations. In fact, some reports have shown that there's a resistance to even consider pregnancy just based on mental health and anxiety. And fetal testing, and even though the primary reason is to reduce the risk of stillbirth, it is another way for us to actually engage with our patients. So patients need to feel cared for. They need to be able to communicate with their providers. And maybe it's not directly related to fetal non-stress test, but it's an opportunity for them to ask a question about a symptom or a prescription or a medication or a dietary question. And those opportunities to engage with our patients and to keep them engaged and invested in their care and invested in their well-being is undoubtedly going to lead to improved satisfaction and outcomes. And then another pillar to this indirect benefit of fetal surveillance is that we don't want patients to feel that they have to go to the emergency room every time they have a complaint. We want to find ways for them to be able to avoid the emergency room and get the care they need at home with their provider directing their care and reducing their burden, anxiety, and risks related to emergency room visits, and not to mention the costs. So now we're going to go to another hypothetical case. And this time Mary is 36 weeks. She's pregnant and she feels decreased fetal movement. Now it's 10 o'clock at night, which some studies have shown is a more common time for patients to recognize decreased fetal movement rather than during their busy day. But it's 10 o'clock at night and she's not sure what to do. Now for her, she lives in the rural Midwest. The closest medical facility with obstetric care services is an hour-and-a-half drive away. She actually went down this road before because a couple months earlier, she had decreased fetal movement in the early third trimester. She called her doctor, made the whole trip, spent a couple hours there, was told everything is fine, and sent home. So she had that false alarm already, which, you know, we know for our patients are going to change their threshold to say, do I want to go through all that again? So she says, no, I can't, I'm not doing this trip again. Let me just see, I'll sleep on it and see how I feel in the morning. But unfortunately, that can lead to disaster. Now, this idea of the Midwest and rural areas of the country is something that's also gotten a lot more attention over the last decade. Only 46% of rural counties actually have a hospital that delivers babies. There's 10 million women in these rural counties that with scarce OB services. And ACOG has a committee opinion giving advice about how to try to start working on the disparities that rural women are affected by. And obviously, the biggest driver of that is access to care. So just adding more statistics to the problem, and this is something that I learned. I was surprised by this, and I grew up in more on the East Coast and not in a rural area. But 50% of rural women drive more than 30 minutes just to get to their nearest medical facility that has perinatal services. So they're driving a half hour or more just to get to a doctor's appointment. And 10% over 100 miles before they can get to their prenatal care. So that's something that just, it might be specific to certain swaths of the country, of the US, but I'm sure that it's still, not only is it a significant problem in the Midwest of in the States, but there's a global issue related to access to care, and geography plays a big role. And no doubt, this does translate to issues in terms of outcomes. And there's 9% greater likelihood for severe maternal morbidity and mortality for a rural patient in the US compared to their counterparts that are in the urban centers. And this is a very interesting and an eye-opening report from the March of Dimes on the maternity care desert crisis across the US, showing statistics by state, showing how there's over 500,000 deliveries a year that are happening in counties with scarce resources from the obstetric's perspective, and probably a week doesn't go by without another report of a labor floor closing or a birthing center closing. So let's use that to transition to this third case. So in terms of, you have these clinics, and they have to take care of a higher volume because practices around them are closing, or they're dealing with a larger geographic space. And we have Dr. Santos, who's a medical director for a large OB/GYN practice. Now she's feeling pressure to overbook the clinical schedule for her providers because we need to increase that access. We have patients that need to be seen. But the practice is already having staffing challenges, and they can't handle the current workload. We know that the staffing shortages, especially amongst medical staff, nursing especially, medical assistance, has been significant since COVID, and it's been a big issue throughout the country. And the providers are getting burned out, and her most senior provider decided to just retire early. They just had enough. And the junior practitioner said, you know what, maybe I just need to go part-time. I can't do this. I need to also think about other aspects of my life. And obviously, this is not something that I think is that far out there in terms of you can picture this kind of situation. So this workforce capacity, it's a significant challenge, and health systems are looking for solutions. We talked about maternity care deserts, but unfortunately they're expanding. And these there are more areas with those closing of labor floors that are having less and less obstetric care available to them. And the US has seen a 5% increase in counties with reduced access since 2020. At the same time, the healthcare workers, it's not just in the rural areas that we're having issues. The demand for healthcare workers is actually going to be heaviest in the most populous states. So those population centers with a concentration of a high volume of patients, we need more and more staff to manage them. But those same areas are actually having fewer potential employees entering the field. So for example, California and New York alone are each projected to have a 500,000 worker shortage by 2026. So it's a mismatch. You have more and more need for higher volume and access, but fewer staff members available to deliver. So here are some other reports on this concept. On the provider side, 50% of OB/GYNs have either experienced or are currently experiencing burnout, which is third amongst all medical specialties. Almost 1 in 5 healthcare workers have quit their job during the COVID pandemic. And I think that a lot of health systems are only slowly starting to come out of that significant shortage of healthcare workers. And 79% of healthcare professionals report that the national shortage has affected them and their place of work, but they've felt the burn, they felt the hurt of not having enough staff to support their practice. So again, let's just play the game and say, how can a remote fetal surveillance program sort of address some of this? And so Dr. Santos, indeed, it's time to innovate. Let's think outside the box, and we're going to implement a remote non-stress test program. So what can that do? It can reduce the in-office patient flow, so alleviating the office schedule. Less patients have to come through those doors, sit in that waiting room, get roomed by the patient, have their vital signs taken by a medical assistant, have the room turned over from patient to patient. It just reduces the overall traffic in the practice, opens up slots under schedule, reduces the wait times, increases everybody's satisfaction. The office staff now is more available. The less work they have to do to manage these patients coming through, the more they're available to support the practitioners and to support the practice. In addition, there are other novel and innovative kind of ways of thinking about remote programs, because you might be able to open up a remote program that's only in the mornings and have a part-time position. You can have remote nurses that are able to log into a remote platform from home. And therefore you can attract nurses that are looking for a little bit less than a typical 40-hour work week or 8 to 5 kind of job. And sure enough, employee and patient satisfaction improves, and they all chip in to send Dr. Santos and her family on a 2-week all expenses paid vacation to Hawaii, which, since we're playing mind games, you might as well have fun with it. But the point being that, the issue of burnout, the issue of stress in the workplace is real. And the more we're able to sort of think about how to bring the work to the patient instead of trying to always just have everybody come in, not only is it more burdensome to the patient, as we talked about in the prior cases, but the practice itself is working harder than it needs to be, is inefficient, isn't able to deploy its resources most efficiently from a patient care and quality perspective and from a revenue perspective. In fact, we interviewed staff members trying to understand the biggest pain points for them when they're running their antenatal testing unit. And here are some of the things they brought up. They have to set up and clean the equipment between each patient, wiping things down. Especially with the pandemic and concern for infection control, which is all important. Managing patients that are off schedule, they come late, and now they are less time. There's more pressure. We're worrying about the patient that's in a slot after them, and the patients that have to be added on for emergencies. Where to accommodate them? Do you keep your schedule open and see less patients, but then that's revenue left on the table and access left on the table, or do you need to find some capacity for add-ons? People having issues with the volume of patients they need to see. Then interference, most testing units, it's not a full room. It might be multiple beds with curtains or semi-complete barriers between them. There's interactions between patients and staff and noise. Hard to focus on each patient's need. We've had patients having ergonomic and workman's comp type of issues, trying to help third trimester patients up and recline them. Patients come with their families and with children, which obviously could be a great experience from the patient side of things, but it can also be disruptive to the workflow and to the patients around them. There's a lot of care coordination that has to happen about the ever-changing testing protocols in a practice, the kinds of tests they need, coordinating it with ultrasound appointments and with prenatal care appointments. And then this one people don't think as much about, but I think there's a lot to be said about, is that there's often a pressure. You put the patient on the monitor, but you don't have time for that patient to spend 30, 40 minutes to get reactive. And especially if they were late and you have a big schedule. So you feel this pressure from the beginning. This patient's got to get off the monitor. And some things you can do to help. Do you use vibroacoustic stimulation? Do you believe that orange juice is going to help the patient? But sometimes some percentage of babies are just not going to be reactive. And you have patients that are getting taken off the monitor before being reactive and having a positive test, and then go into, let's say, a biophysical profile or some more monitoring on the labor floor, even though with just a little bit of time and patience and capacity, you might have been able to avoid that. And finally, it's that some patients need prolonged monitoring. We've all had situations, it probably happens every day in the busier units. The fetus looks great on the monitor, but it has like an isolated, variable deceleration for 60 seconds or so. Well, I think the baby's fine, but I want more time. I want to be able to keep that baby on the monitor for, let's say, a half hour to make sure that it's reactive and it's not a recurring thing, it's an isolated thing. but I can't do that in my office because I have 5 more patients waiting for that bed. So the trigger to be able, and the threshold to have to send patients for higher levels of surveillance and intervention, just because of logistics, not necessarily because that's what the patient needs. Now, of course, sometimes, yes, the patient needs to be delivered. That's why we do the testing. But many times, and in fact, I would argue the majority of times that we're intervening on a patient is not because there's a clear 100% need. It's because it might be difficult for me to continue to manage them as an outpatient confidently with my workflow. I need some more information. Let me send them to a higher level of care. In fact, we know that this question about how much time to wait for reactivity, there's some evidence behind it, but even if it's just a logical thing, and I don't know how much time any of you use in your clinic in terms of how long you let the staff keep a patient on the monitor to wait for reactivity. But I go to several different sites, and some sites, 30 minutes, sometimes 20 minutes. Rarely it's 40 minutes, definitely not with regularity. And we know that the non-reactivity rates decrease the more time you give the patient to be reactive. So this is an older study with a slightly different definition of reactivity, but just to understand the concept, that in that study, 25% of NSTs were non-reactive at 20 minutes, and went down to 5% at 40 minutes, and down to 1% in 80 minutes. Now, does every patient need 80 minutes? Of course not. In fact, very, very few, if any, will. However, the general idea is that if you wait, give them a little bit of time, you have a little bit more patience, have a little bit of a higher threshold before we intervene and let nature do what it's supposed to do with a watchful eye, maybe we can reduce the false positive risks and reduce our interventions. And as I referred to earlier, same thing with the isolated deceleration. Even ACOG will say an isolated mild deceleration is not associated with adverse outcome if it's not recurrent or severe. And yet, I would imagine that we're not the only practice where there are times where it's difficult for us to keep the patient on the monitor long enough to get our reassurance, and we do, ask for some additional monitoring time on the labor floor just because we can't accommodate it as an outpatient. So we had mentioned OB emergency room visits in terms of the burden to the patients and the anxiety that provoke for the patient, but and 1 in 3 patients end up having a triage visit in pregnancy that's not a delivery, but just a triage visit. And the volume of obstetric triage in most hospitals actually exceeds the entire birth volume, right? So you have more visits to the emergency room than you actually have births by up to 50%. So a lot of triage units are actually dealing with issues of capacity and how to manage all those triages when you're not going to bring them in for delivery, and you have to manage those patients and send them out. A lot of patients even go into the emergency room just to get prenatal care. So trying to clutter these triage centers associated with labor floors or emergency rooms in general is definitely a well acknowledged goal. And then finally, the cost, $2.5 billion of OB emergency room costs each year in the US. And the same test, so if you just want an extra hour of monitoring, but it can be done outpatient and cheaply compared to now being charged for an emergency room visit, is an obvious gap that we can try to address. So I'm gonna have it, now I'm gonna sort of try to take one step further, okay? So I think most of the stuff I discussed may or may not be entirely new to everybody here. Hopefully it just stimulated some ideas about what different kinds of aspects that remote monitoring might address in our delivery of healthcare from both the patient's perspective, the clinician's perspective, and the healthcare system's perspective. But this is just even a little bit more out there, but I wanna put this out there as a food for thought kind of case. So here we have a 37-year-old, first pregnancy. It took her a long time to get pregnant with multiple IVF cycles, and she's finally pregnant. But she's diagnosed with placenta previa at 20 weeks. Now, placenta previa at 20 weeks, 3 to 5% of pregnancies at least have a placenta previa, most of them resolve, but not all of them. And we've published, as others have, that the risks of a resolved previa, but it's a very, very common clinical scenario we've all had. Now, this patient now indeed has vaginal bleeding at 30 weeks. And the ultrasound shows actually her previa is resolved. She just had a bleed, but we admit her, monitor her, maybe give her some corticosteroids for fetal lung development. We watch her for a few days. And nobody has a magic answer. How long do you watch a patient like this? I'm sure some health centers are, keep them in for longer, some for shorter. Maybe it has to do with again, that rural issue, where does the patient live, what are other risk factors, et cetera. But in many patients, in many centers, there will become a time where you're like, hey, she's stable enough to go. Is it at 48 hours, 72? I'm not here to debate that. But I would imagine that there's sometimes a disconnect between when the clinician thinks it may be okay to go, when the patient feels too anxious to go or not to go. And it could be the other way around. The patient wants to get out of there and the clinician's not comfortable. So in this situation that I made up, hypothetically, you recommend discharge from the hospital because she's been stable for a few days already. She hasn't bled since she got there. She's gotten her steroids. The baby looks beautiful on the monitor. She's not in labor. She's not dilated. There's no previa. And you want to recommend to send her home, but she's anxious. She took so long to get pregnant. She had a bleeding episode. She wants to stay there till delivery. You currently don't have an indication to deliver her for another 2 months or more. And you're not really feeling like you want to commit to that kind of delivery. So you can imagine in that kind of situation, having the ability to monitor the patient at home might help you in that dialogue with the patient in terms of reassuring and giving you other opportunities and options. So we also know that a prolonged hospitalization has significant, probably under-recognized or under-prioritized impacts on the patient. The separation from family, and this was even worse during the pandemic when most hospitals had significant limitations on visitation. But even now, most hospitals, won't necessarily have the capacity to have, overnight visitors, or many of them at least. There's loss of income and all the other costs related to childcare or other responsibilities that a patient may have that they can't necessarily address when they're in the hospital. And there's significant risks of mental health issues related to hospitalization during pregnancy that are often manifest actually even during that hospitalization, whether or not they came into the pregnancy with any mental health diagnosis. Even just being in the hospital for a prolonged period can cause these issues. There's issues related to nosocomial infections, venous thromboembolism risk from being admitted for a while. There's iatrogenic interventions in the patient's in the hospital. The threshold to intervene when the patient's there in the hospital is always going to be lower, and that's a real thing. So once the patient's in the hospital, once the patient presents to the hospital, their risk of being intervened on for the same exact symptoms is going to skyrocket just because they're there. And then there's the cost, which we can't in this day and age especially, but we can't discount. The hospital costs per day, the billions of dollars that go into maternal health care in terms of just hospitalizations each year. So just throwing the idea out there, this is not a recommendation, it's not a clinical recommendation, it's not a standard of care. But I think, me personally, that there is probably some scenario that a clinician, and everybody might have a different opinion about which diagnosis and which scenario, but there are probably multiple different kinds of scenarios where the overall counseling of the patient and the ultimate decision by the shared decision-making of the patient and the clinician can be adjusted and hopefully improved by having the capacity to do remote fetal monitoring. Whether that's resolved bleeding, like the example we just gave, somebody with preeclampsia without severe features, how long does that patient stay in the hospital for? How long do you watch them for? Would you feel more comfortable watching them if you knew fetal growth restriction, even preterm labor, and maybe even PPROM, where again, not the standard of care, and definitely in the United States, but there are definitely many centers in Europe that discharge patients that are stable with ruptured membranes for outpatient management. Now, this is actually just emerging evidence that this was just published a couple months ago. The Fetal trial, which was a multi-site randomized controlled trial that was comparing hospitalization versus telemonitoring with home non-stress tests and blood pressures. So they took patients who, again, different diagnoses, and maybe in other scenarios, maybe even in the United States, you wouldn't consider admission, but overall, they're high-risk patients that need some sort of serial surveillance. And what they were comparing was doing this in the hospital, just saying you have preeclampsia, even if it's not severe features, just come into the hospital, versus, or PPROM in the hospital, versus let's watch you closely at home with daily monitoring. And you see the breakdown there, and there was around, I think it was 200 patients in each arm, I believe, or 100 patients in each arm. And around a third of the patients had preeclampsia, a little over a third had PPROM, ruptured membranes, up to 20% had growth restriction. Recurrent decreased fetal movement was another one. And their composite outcome was mortality, low APGAR score, acidosis, maternal morbidity, NICU admission, and C-section rates. And they found in that study, which was they powered for a non-inferiority, meaning they weren't necessarily powered to say, I'm going to see a difference. They just want to have enough patients in the study to say that the overall outcomes should be similar, whether you are at home versus in the hospital. And they show that their prevalence of the composite outcome was actually lower in the telemonitoring group, 31% versus 40%. And again, their goal was not to say, I'm going to improve outcomes, although their small data set showed that, but they felt confident in their power analysis that even if we didn't lower the adverse outcome, they should be similar. And if they're similar, but the patient is at home and it's cheaper, and then something we should consider. And they did do satisfaction surveys and showed improved patient satisfaction scores in the telemonitoring group. And the other thing to consider with remote monitoring is the cost. And again, if you're a clinician and you're just trying to get your patients in and out, and you're trying to see patients from a volume perspective or just to meet the patient needs, you sometimes it's hard to prioritize the overall healthcare system costs because you're not an insurance company or you're not a health system. But whether we like it or not, all of these things are interrelated. And the more we do to invest in that our healthcare systems that we work in are financially solvent and in a good position, then we can get the resources to then expand and to get the more support staff. So it all does interdigitate with each other, whether we like it or not. And so the cost of healthcare is something that we can't ignore. There are a couple of reports out of Europe that modeled or did small pilots related to remote monitoring in pregnancy, again, more for the dehospitalization perspective, and showed significant multi-million-dollar savings in their small populations. And again, with either 58,000 or 170,000 annual births, compare that to the 3.5 to 4 million births in the United States. You can imagine the amount of healthcare savings that are possible. And then the hotel study that I referenced in the prior slide that looked at outcomes also did a cost analysis and showed significant cost savings per pregnancy in a telemonitoring group, even though they did like daily monitoring and frequent interactions with the patients. So from both a quality of care perspective, from a patient satisfaction and mental health perspective, and from a cost perspective, this idea, again, I'm not saying that there's a new standard of care, especially in the States, but when we want to try to be forward thinking and we have a new technology, we have to think about not just our current state, but what doors does it open when we're trying to be a little bit more creative and innovative. And just lastly, this is actually my last slide. So I mentioned that we did a couple of validation trials that were sponsored by Nuvo, and now I'm launching a randomized trial that's funded by the NIH. But this is a small pilot that was sponsored by Nuvo. And again, the idea here is not to specifically talk about their device versus any other devices that you might come across, but we just wanted to, for ourselves, understand what the experience would be like to actually send a patient home and have a non-stress test. And so in this small cohort, which was just recently accepted for publication in ACOG, we had 131 remote non-stress tests performed, and had 94% of them were interpretable. So the patient was able to get an interpretable non-stress test at home. And the vast majority, almost 90% of patients, were able to avoid an in-person visit. So imagine for these patients that 90% of the time, you can tell them they're able to stay at home. And in fact, of the people that had to come in, many of the times it wasn't even about the tracing, that it was a blood pressure thing that they may have to come in for anyways. So it's not necessarily just from the tracing. And we did a usability scale survey as well, and they all felt that they were able to use the system. They would want to do remote monitoring in the future. 96% of the respondents said that as well. So it is feasible. The technologies are out there, and more technologies are coming to market. And I think it's high time for us to start thinking about how do we take all we've learned from COVID, all we've learned about telemedicine, all we're learning and continuing to learn about disparities of healthcare, social and structural determinants of healthcare, and our ability to meet the patient where they are, that we can't just be paternalistic and say, you got to follow our recommendations, and if you didn't, that's on you. No, we want what's best for the patient. We're altruistic. We want everybody to be able to enjoy the gift of bearing a child if that's what they choose. And technology is finally there to give us more opportunities to be creative. And that's sort of what I want to put out there. And that's all. That's the end of my presentation, and I'm happy to take any feedback or questions from the audience.
Great stuff, Nadav. Thank you for sharing that. A lot to think about, a lot of really insightful ideas there. So not surprisingly, triggered more than a few questions. The first one, or actually a few of these, we hear a fair bit, but one of the most common things we hear is a question around what happens with a non-reactive NST or concerning deceleration or any other concerning thing you see in the trace when the patient is monitored remotely. What happens then?
Yeah, I agree. That's a great question, and definitely a question we get, or I get a bunch. So I think there's a couple of things to consider. One is what I presented, that some of those non-reactive NSTs or that an isolated deceleration that you feel the need to act on when they're in front of you. But I think that the ability to monitor remotely allows me to be more patient, because I don't have to worry about the pressure of getting a patient off the monitor or getting the next patient on the monitor, having my staff take a patient off. I can be more patient, giving more time to get the patient to be reactive and more time to get reassurance after an isolated deceleration without having to send the patient to the hospital. So the fact that the remote monitoring can be extended and applied as frequently or for as long as you want, as the clinician wants, without an additional burden to the practice or to the provider, will hopefully lower the incidence of all those things happening. That being said, there will be truly non-reactive or true decelerations. And my response to that would be twofold. The first is, thankfully, it's very, very rare. And even though we've all probably had that situation of we wanted to rush somebody to the hospital with a bad tracing, the incidence compared to all the non-stresses that we do, that we feel the need to rush somebody over to the hospital. And once they get there, and we all know that, they end up most of the time doing okay and not getting delivered for a few hours or longer or days. So the differences between having this done at home and sending the patient to the hospital with calling 911 or driving themselves versus doing that from your medical office is a very uncommon scenario. And I would say that for many practices, especially most of them that are not hospital-based, you're still going to have that same issue. Some of our practices, you still have to call 911 to drive them 3 blocks to the hospital. And so therefore, there's not that much of a difference. I will say, like anything else, non-stress, you're not going to be able to prevent every single accident. And in fact, ACOG itself would say that, cord accidents and these acute issues are not what the non-stress test is designed to prevent. And we shouldn't be held to the standard or be afraid of an unrealistic standard that somebody that's high risk that's on the monitor will be able to prevent every single adverse outcome. And so I think with the proper counseling, with understanding how to best deploy this kind of technology and making sure that it's a patient that's engaged and has their ability to act, I think it's going to be proven to be a safe option.
Yeah, that makes a lot of sense. Before I get to the other questions, just as a quick reminder to any attendees who joined late, please do feel free to submit any questions you have through the Q&A interface in Zoom, and we'll get to those as we get through some of these other questions. The next group of questions, we got several around clinical protocols, and if a clinical protocol involves a fluid check with every NST, how do you see this working with a care protocol where the NSTs are shifted into a remote setting?
Yeah, also a very, very spot-on question and a very fair one. So, even though ACOG has its guidelines about how frequently to monitor and which weeks and which indications, I'm sure there's a lot of variability in care. You have some places that focus on biophysical profile only without an NST versus NST versus the modified. So there's no one right answer, and ACOG will just have them all as being a primary surveillance test. I also recognize, as I mentioned in the slide, that there is a small incremental difference in the reported false negative rate and adding the fluid to make it a modified biophysical might help you. But in truth, those data are old. They're like, 3-4 decades old. And nowadays, when ultrasound is so common and people are getting growth ultrasounds all the time, You know, a lot of these high-risk women are getting a growth ultrasound once, or if not 2 or 3 times in the 3rd trimester. The ability to diagnose the real high-risk indications for oligohydramnios, which are like fluid growth restriction and post-dates, like those things are much more unlikely to be missed in the current care protocols. That being said, you know, the frequency with which to check a fluid, is it just every 3 or 4 weeks with the growth ultrasound, or maybe have the patient come in every other week or every week? That's going to be a personalized decision. Each practitioner for each indication is going to have to make a decision. However, whether they should need it every session or you know, every week or twice a week is probably significant overkill, and I think the data show that. And in addition, well, I've had patients who, even if they want to come in and get on the ultrasound for a quick deepest vertical pocket, which takes, you know, a whole of 2 minutes to get, they'd rather still get their non-stress test at home at their own, you know, at their own schedule, in the comfort of their home with a, you know, with a magazine and a cup of coffee or whatever it is, and then once they're reactive, they come in, they get their quick DVP, and they leave. They still have a much shorter experience in the office. They don't have to wait for the non-stress test share and the ultrasound. They just wait for the ultrasound. So there's a lot of benefit. So whether an individual practitioner will decide to decrease the amount of times they get a fluid check versus eliminate them for certain indications, or whether they still would offer it but feel like there's benefit in terms of workflow and satisfaction, that remains to be seen. It's a new technology, but I don't think I don't think it significantly removes the benefit that we're talking about here.
Yep, agreed. We had one question come in about the limitations around medical practice across state lines and how that comes into play with remote fetal monitoring.
Right. Yeah. That's also a good question. Yeah, I wouldn't call myself a billing expert, but I have some operations experience, and I know that, you know, each state and each payer may have different guidelines about what they would or would not, you know, want patient and provider to do if they were not in the same state. Whether the provider should be licensed in the state where the patient is, which is probably the safest bet. And we know that there were a lot of exceptions made during COVID and the pandemic. A lot of payers and state insurances have maintained a lot of those permissions, and some are now trying to figure out where their sweet spot is in terms of those policies. So it definitely would have to be individualized by region and practice and payer. That being said, I think it's entirely clear and accepted that with the pandemic experience, that telehealth and virtual care is here to stay. And that investing in this idea of bringing the care to the patient is something that is just a win-win-win all around. It's a reduced cost for the payer, reduced cost for the healthcare system, increased efficiency for the practice, decreased burden for the patient. So I feel like I couldn't give an answer for any specific payer or state, but it is something that should be on the radar if somebody's considering an implementation. But there are avenues for having success with telehealth programs.
And the last set of questions we've gotten in so far relate to, and this is probably a good segue from the last question around who pays for the remote fetal monitoring, and more specifically, how are remote NSTs billed, and are they reimbursed from a payer perspective? And I'm happy to jump in on this as well.
Yeah, I don't want to get too specific to a specific product, but I do know from my exposure, both through Nuvo and in general, that that a non-stress test is a non-stress test is a non-stress test, and the code for non-stress test should apply to this as well. Whether or not some modifier related to place of service and some technical sort of configurations of the bill from a global versus splitting the facility fee, like the general idea that a remote monitor is still a non-stress test is there. It's now it becomes a mechanism at how to get reimbursed, and what each payer is going to sort of what approach they're going to take in terms of tracking these cases and reimbursing for them. But I do think that what we as a field in terms of maternal fetal medicine can and should do is the more, like, I think for a lot of payers, this is so new that they just haven't really wrapped their head around this idea. It's not the same as like the remote monitoring codes and the 99 codes, where it's like an E&M visit remotely. It's just not. And therefore, the 59025 code has never had to consider place of service before, other than maybe hospital-based versus outpatient, but never home and never remote. So I think that we are in the early stages where a lot of sort of both proof of concept, but also initial early adopters of the more innovative practices and the more innovative payers that are going to start building that momentum. And what we can do as a field is not sort of shy away and let somebody else figure it out, but really say, listen, this is important. If we believe that it's important for our patients, important for the next wave of the future, and let's sort of catalyze change by speaking to our payers and say, hey, listen, we want this program. You know, there are several states I know that have put remote fetal monitoring into the actual laws of the Medicaid laws of the state to start piloting these kinds of programs to address healthcare. There's been some payers that have put out endorsements for remote fetal monitoring. So the trend is there, and you know, in a year from now, I'm sure, I'm confident that it'll be even more prevalent. But we're in the early stages, but that's the point of these kinds of interactions and webinars, is really just to sort of like stimulate ideas and creative thinking for those who feel ready to innovate.
Yeah, absolutely. And I'll just build on that a little bit and say that with Nuvo's experience specifically, we have seen public and private payers reimbursing the same CPT code 59025 for in-clinic NSTs, using that same code and reimbursing for remote NSTs under that same code. So that experience is certainly holding. So I believe we have, let me just do one last check. I believe we have gotten through all of our questions that have been submitted. And we are right near the top of the hour. So that timing is just about perfect. So I'll go ahead and wrap up and just say thanks again. First and foremost, Dr. Schwartz, thank you for your time and all the insights you shared today. A really compelling presentation. And I'll say thanks to everyone who took time out of their busy schedules to attend here today. I will follow up with the recording of the webinar, and feel free to share that with anyone that you think might be interested. And thanks again for your interest in this topic. And we look forward to seeing and talking soon. Thanks again, everyone.
Thank you.